Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Welcome back to another episode of Pod Patrol with your host, Dr. Jeff Dikis.
And Dr. Ashley Dikis.
How you doing today?
Wonderful. Thank you.
Interesting.
Yeah.
All right. So what do you want to talk about today? So you work at the school. And what's the biggest headache working at the school? What's the thing that you wish you didn't have to deal with?
Oh, I mean, I think she's something that's specific to academia and not just practice in general.
Yeah, because it's different than what I do. My patients cause me headaches when they're non-compliant and,
sure,
out of pain medicine again. But yeah. What's the biggest headache for you? Because it's different.
It is. I think one of my favorite things about the job is the fact that I am we always have multiple things going on, right? So we're allocated time to be in clinic, to do research, to be on committees, all these different things, have administrative appointments, whatever it may be. But the problem is that sometimes when you are a jack of all trades, you're giving a little bit of yourself to all these different things, but you're not giving one particular area all of your focus. And so sometimes it's actually really hard. I think from a practice standpoint in particular, I actually feel that the most from a clinical. And I think maybe especially because I lived that, kind of full, normal clinician life before this.
Yeah.
And so I feel this kind of tension with that on a pretty regular basis of the fact that I am a part-time clinician.
Yeah.
But that's really challenging, I think, because then I'm trying to give my attention to a bunch of other things that are also important parts of my job. But the clinical kind of side of things, that's always moving forward, right? There's always patients calling that need things or people that need to be seen. And when your schedule is a little bit more limited and your kind of time that you can dedicate to that is different, I find that actually most of the time, honestly, to be one of the more challenging kind of aspects of our job.
Yeah, I could see that. I mean, you're stretched a little thin in each of those activities, but on the flip side, you do have multiple of you helping out.
Absolutely. Yeah. And that's one of the benefits. Yeah. Which is different than your, situation.
Right. If I'm out, then at least as it is right now. So I'm going to be starting to work with a physician assistant who will kind of help me out quite a bit. But as of right now, when I'm out, if I go on vacation, it's a nightmare. Before and after I go out, it's, builds up and is just out of control. So I'm almost penalized for going that time. At least you have some help there. So I get that you're stretched thin, but at least you have some help there. So,
and I think that's really where you have to, when you're looking for your job scenario, right? Of what type of practice you are looking into, what kind of you have to envision, what do you want your kind of time to look like as far as time dedicated to different aspects of practice, and what are the pros and cons of having a situation like yours where you're the one who all the patients that need to see foot and ankle come and see you because you're the one. But that also means, like you said, whenever you're gone, then it's that much harder than sharing that with a partner or a group.
So what do you see most in the clinic? What kind of stuff are you seeing most of the time? Because I know what you do, but it's it's rangy.
It is rangy. Yeah. I mean, again, a little of that also goes back to kind of being the part-time clinician as well. So sometimes that makes things interesting. Certainly we are teaching clinic. And so we see our fair share of, high-risk foot care, diabetic foot care, those types of things. That absolutely is as part of our practice. But we also see a really wide range of other things, right? So we see sports med patients. We see a lot of like bread and butter podiatry, hammer toes, bunions, plantar fasciitis, ankle sprains. And we also end up with a lot of patients with Charcot neuroarthropathy, with, significant deformities, patients who need big reconstructive surgeries, which is also, I think, a cool thing about being in the academic setting is we can, on especially those larger cases, sometimes we'll even scrub those, together, have two of the faculty there to kind of tackle some of those larger cases. And we can do that because we have the flexibility, of being in an academic institution. So definitely some pros and cons there, but it's pretty wide ranging and it varies a lot day to day.
Yeah. So you're at the main clinic a couple days a week, and then you go out to what we call the RecPlex, which is a sports medicine, physical therapy clinic out there. So you're obviously going to see different types of patients at each of those clinics just by the nature of who's showing up to each of those places. So I think that's kind of unique. I only have one office, so
Yeah, and I think you different than us. We have a call schedule throughout the group, but we're not on the call schedule for like the ER at the hospital. We're covering call for our patients and and some new consults that may come in, but for the most part, we're covering our own patients, and so that's different. You'll notice one of the things I didn't mention is that we don't therefore end up with a ton of trauma. We do have some that comes in through patients who are already established with us, or patients who come in as a new patient, as more of an outpatient type of thing. But that's one of the things that we don't see nearly in the volume that you do in a practice like yours, where you're actually on a call schedule with the emergency department, and there you get a lot of trauma through that.
Yeah, which is not that bad though. I mean, I'm on call almost 24 hours a day, 7 days, 365. If I'm out of town, I'm not on call, but that's the benefit of kind of a smaller hospital, is that complicated urgent stuff gets shipped right on down the road, and the kind of the sweet spot stuff gets to stay. So I don't actually have to, go into the ER very often.
Yeah. You've got a good setup there. Can you still hear me?
I can hear you.
Oh, okay. My headphones did something funny.
I wish I could mute you. On here, I can mute you. In real life, I cannot. Can we get this into the real life where I can mute?
Are we gonna get divorced on a podcast? Has anybody ever done that yet? Or can we be the first? Do we get to be in like the Guinness Book of World Records or something if we get divorced on a podcast?
What if you're downstairs? I'm up here in the podcast studio. There's a knock at the door. I'm like, oh, hold on. What's going on? And I get served papers in my own house. Like, whoa, what is this? And you're just sitting there smiling. That would be a first.
I'm going to keep that one locked away.
Yeah, keep that.
For the future.
That would actually probably be pretty entertaining. So, I don't know. Let's jump into a case. You want to jump into a case?
Sure, let's do it.
Let's get wild. So this is a young girl that came into my office with this x-ray. I think she was about 22 years old. It was kind of a mundane injury. I think it was dancing at a wedding or something. So for those only listening, there's a very odd fifth metatarsal base fracture that looks longitudinal. So I've never seen this before. Have you ever seen anything like this?
No. And am I seeing just some kind of overlap on that medial aspect, or is that another fracture line there within your circle?
I think it's obscured by my circle there, but
I couldn't tell.
I think it's fourth, fifth base
good.
overlap. But yeah, just that weird transverse fifth metatarsal base fracture. And she came in and I looked at her x-ray. I was like, I have never seen this before. It is completely turned 90 degrees horizontal to the normal alignment of the fifth metatarsal base styler process. Like, I don't even know how this happens. Usually you get that proximal pull, the peroneus brevis, that pulls the fracture. That's by nature what makes it an avulsion fracture, is the pull of something that attaches to that bone. But it pulls it linearly proximal. It doesn't do some sort of weird rotation. And if you do have a weird rotation, then it tends to be more of a Jones fracture, not an avulsion, because of the rotational component that we know with that lateral shifting of your body weight of a foot that causes that Jones fracture. So I don't know. What are your thoughts on that?
Yeah, it makes you think from a mechanism standpoint that instead of the fracture occurring during a twisting moment, like a rotational moment, that it's almost like she had some kind of weird thing where it fractured and then she had like a twisting injury. Do you know what I mean? Like you try to think of what would allow that to turn. That's
Yeah.
odd. Yeah.
I was trying to think of if they were
Regardless, it looks weird.
yeah. I was trying to think if they were in like a high heel, if they could have like
Sure.
started to shift and twist and then it broke and then the shoe gave way or something and then it rotated weird, or maybe her foot bent underneath of her. I don't know. Regardless, it's strange. So
Yeah.
we got an AP and oblique X-ray here that kind of confirms that it is strange and odd. And so there is no way to treat this non-operatively. This is an operative, 100% operative case. I don't know, but what are your thoughts there for like fixation? Because you have to kind of plan ahead. Yeah, I'm going to go in, I'm going to put it back where it needs to go. I'll worry about the reduction when I'm in there. But then how are you going to think about fixating that?
Yeah, I mean, again, that's so strange because it's not even in a normal like alignment for if we did have a styloid fracture that you were gonna, put a screw across or something, because it is a really odd fracture pattern and it's intra-articular, which I think is challenging. So to me, that almost feels like it's got to be some kind of a plate. How much did the brevis or tertius attachment get in your way on fixation for this? Or I guess not even so much the fixation for reduction of the fragment.
A ton. Yeah, so this piece here obviously needs to be rotated 90 degrees counterclockwise to get back into alignment there. So, and then, people might think, okay, is that a Jones fracture? Well, it's not a Jones fracture. It's a styloid process fracture. And we could confirm that based on the alignment. And if you see the x-rays, you know that it's not a Jones fracture. So my concern with fixation here is typically when we do a Jones fracture, we're going to do the intermedullary screw fixation down the canal of the fifth metatarsal, throw the wire, drill. It's a cannulated technique with a solid screw. Usually a 5.5 millimeter screw is what I would typically use 95% of the time. Sits in good alignment. The concern with this, though, is that the fracture is so small that you drill through that and you break it, in a T fashion. It has a transverse fracture, and then you make a sagittal fracture right through the existing fracture. And then you end up putting a hook plate on it. So instead of just fracturing it and then going to the hook plate, let's just jump to the hook plate and, go ahead and fixate that. So I opened it up and it was extremely difficult to get that reduced.
Yeah, I can imagine. I mean, you're right there with, you got brevis attachment, you got peroneus tertius attachment, ligamentous attachments there. I imagine that's challenging.
Yeah, I'll just let this video play in the background so you can watch me struggle trying to get this piece rotated. So this is me live. Not live, but like it was recorded, as is, no cuts, just me struggling to try to get this piece de-rotated and get it back into proper alignment in there. So it was really tricky. So like you said, the ligamentous and tendinous attachments, you could release all that stuff, but then you have detached the tendon. So if you detach all the soft tissue, then it's an easy alignment, or it's an easy reduction. But then you have, devascularized the entire piece of bone, and then you have to figure out a way to reattach the peroneus brevis. Oh, by the way, that's kind of important. So
we generally like that to stay intact.
You don't necessarily want to just release that to get it reduced. So This is me. I'm kind of freeing up some of this stuff kind of plantarly, and then I'm using a baby Homan there to kind of curve underneath of it and trying to push the top down and push the bottom back so that it reduces back into better alignment there. So eventually, after a bit of struggling, I got it back into alignment. So it's kind of fun when I have someone start videotaping and then the pressure's on. Like, okay, now hurry up, do the thing. We're videotaping. We're not going to tape for 45 minutes. Like, come on, man. Like,
better get it right.
Tape is rolling, time is money, but eventually got it back into good alignment there. So, and then here you can see kind of get it into better alignment and then kind of finagle it a little bit. And as it goes down, you can see it got it back into perfect alignment there. It fits in like a puzzle piece. It's so satisfying when you get a fracture and you reduce it and you get it back into optimal alignment and it just fits together just so perfectly. It almost disappears. You can see that there. As you reduce it, the fracture disappears. You're like, where'd it go? It's like, that's how you know it's perfect. So there's something so satisfying about fracture reduction when it gets back into that alignment.
Yeah, especially when you've got somewhere where you can actually really visualize, get that good cortical read. Like that you're right. Then you know you've really gotten it back exactly where it needs to go.
Yeah. So put this hook plate on there. The downside for me for hook plates is that it does cause some irritation. If you reach down to your own foot and you feel that lateral aspect of the fifth metatarsal base, there's nothing there. You know, there's skin and bone. And so you put a plate over top of that. Even though these are locking screws, they sit down flush. They don't sit up above the plate at all. It is an area of irritation. So that is one that I commonly tell them, hey, this might cause you some irritation or rubbing or trouble. We'd have to go in and take that plate back out. But, you know, such is the nature of trying to reduce that fracture and get it back into optimal alignment. So
did you put a small like temporary wire across that fracture once it reduced, or once you got it down, like in that second video, were you able just to kind of manually hold on to it or clamp it or something?
So what I've learned over the years, and this is not me discovering this, anyone who does trauma will tell you this, the harder it is to reduce a fracture, the more stable it is once you get it into alignment. So if it's easy to reduce, then it pops right back out, you know, ankle or whatever it may be. But if it's really hard to get it, I got to fight it to get it back in, then it doesn't tend to re-dislocate or re-sublux. It tends to be pretty stable. So I think I did put a little wire across that, but I'm not sure that I even needed it because it was so hard to get it reduced that it wasn't going to spontaneously go back to where it started.
Fair enough.
But yeah, if you can almost throw the wire like you would for a Jones fracture. Started at that high and tight fifth metatarsal base, start to go down the medullary canal, pin it, then you put the hook plate on there, and you can eccentrically drill it to try to get some compression across through those hooks. They don't usually sit down into the bone as much as you'd want them to. You think like, okay, these are going to suck right into the bone. Some of the companies I've used even have a little template with these 2 holes, and you drill 2 holes and then you sink those teeth down in there and you kind of impact it. Those work a little bit better than the ones that just kind of sit on top of the bone. But it never sits down as flush as you want it to. Sometimes it feels flush and you get an x-ray and it looks like you're off the bone by like a centimeter. You're like, what? How is that even possible? Like, because there's so much tendinous attachment there. There's so much soft tissue that you're like, this is as far down as I can put this. And you get an x-ray and it looks like you have no clue what you're doing. Radiology is going to read your x-rays afterwards and be like, this guy stinks.
That's the subtext of their read. You can tell when they're thinking that it's not, when they're like, adequate alignment.
Yeah, adequate alignment, yeah. near anatomic alignment.
Yeah.
Wait, what was that near part? Go back. What was the near? Did you say anatomic or near anatomic?
Oh, God bless radiology. That's like, it's hard, right? To just take an image of something and you're going to be like, all right, what's going on here? Like not having any clinical context, like that's challenging. But yeah, you can definitely tell sometimes the subtext of their text.
I assume they would have to go back and look at some preoperative things
for sure.
And some, just to have some context and be like, oh, okay, well, yeah, I guess that does look better. Because sometimes they look at,
if they have it, sometimes they don't though, right? Like for our patients, if they came into our clinic and we're in a separate PAC system, we go to the hospital, they're not going to have access to that.
Right.
Anyway, yeah.
Yeah, I can tell you're having a great time, aren't you?
I just love talking about feet on the weekend. I just wait all week thinking about feet, seeing feet, teaching people about feet. And I'm like, you know what I'd love to do this weekend? Let's talk about some feet.
Tell me about those feet. All right, this is an interesting case because of what happened intraoperatively, not because of the original X-ray. So,
Okay.
um, I don't know.
You're not going to make me classify this by Log Hansen, are you?
No, I was going to say go ahead and read this X-ray, but that's just because I've been I've been working with the students too much. Like, all right, go ahead and read this X-ray, and then I
Yeah.
tune out, and I'm like, wait, what'd you say, Weber? What? No, that's not. No, no, yeah, they're usually pretty good. So,
Yeah.
for those listening, we have a kind of an isolated distal fibula fracture, Weber B, that oblique rotational component of the distal fibula with lateral translation of the fibula, but without significant increased medial clear space. So kind of that distal fibula fracture laterally translated, but the ankle mortise kind of looks okay. And when the ankle joint mortise looks okay, then I know that this is one fibula reduction, 1 5-second fibula reduction from perfection. Now, you can make an argument. I think this was like a 60-some-year-old lady who broke her ankle, came in, and this is a very quick reduction intraoperatively. You could almost make the argument, okay, well, maybe we should do non-op, but, there's lateral translation there, and you can look at the lateral gutter, and it's just gapping. So I don't tend to let these fly, even though some people say the fibula is a non-wavering bone. There's no syndesmotic instability. Ankle joint mortise looks reasonable. Okay, at that point, you have to weigh the pros and cons with their comorbidities. But with this, I had planned, let's go in and do an intramedullary fibular nail. So I go into the OR and I plan for an intramedullary nail. This is with a percutaneous reduction. So that's me with the wire up the fibula. The wire went well. And that's me reaming for the nail. So how does that look to you? Does it look terrible or awful?
It looks a little lateral. I can't really tell very well on this picture, but
It looks horrendous.
yeah, something's not good.
Right. And so I'm sitting there and I've already reduced it. So I should find a picture of the reduction, and the ankle joint mortise looks fine. Mm-hmm. And then I throw the wire and then I start reaming, and it causes all this distraction, this gapping and this ankle varus, this tilt and this gapping. I'm like, what is happening? This looks horrible. This is not supposed to be happening. I've put in enough fibular nails that this is not supposed to be happening. And so what was happening is that there was like an accessory fracture. So there's this extra piece of bone in there. Can you see that?
Yeah.
This extra flap of bone that was preventing my reduction when I got in there. And so the reduction, it was not fantastic, even though I thought that it was. And the reaming system was causing the fracture to spontaneously re-dislocate. Mm-hmm. And I wasn't maintaining reduction. So the reamer was going through the distal piece, hitting that fracture, that butterfly, that comminuted piece of bone, and kicking the reamer laterally, which was displacing the fracture before I got to the more proximal segment of the fibula. So the wire was fine. It didn't cause that because it was truly intramedullary. But the reamer was big enough that it hit the outside, hit that fracture, caused the lateralization of the reaming system, and then caused the fracture to look horrible.
Yeah.
And at this point, I had continued to ream, and I even went in. So this is my reduction here. It's a terrible X-ray.
Yeah.
But, because it's like a oblique, but like not even a true oblique, because you can look at the medial gutter. It looks way off.
Yeah.
But the reduction was like, okay. But keep in mind, this is percutaneous. So you're trying to keep it minimal incision. And so this is through like 2 tiny little poke holes. This is not a true open reduction. But the reduction looked okay. And I started to put and it looked so bad, and I had to make a decision. And I'm sitting there with the nail in this, I don't know how many $1,000 nail in the bone, and thinking, this doesn't look good. Like, I can't leave it like this. It's already in there. If I pull this out, it's a lot of money. But I had to make a decision: leave the nail in or pull it out and go to convert it to an open. And obviously I already showed you that little fracture fragment. So you already saw that I could made that decision, pulled the nail out, converted it to an open procedure, found that little accessory comminuted fragment, reduced it, and then put a plate on and stabilized it like you see here. And I was much more comfortable with leaving the OR with this than I was with a malreduced fibular nail. So I don't know how many people have issues with that, or if people listening are like, oh yeah, that happens all the time, or if they're like, what, you're terrible, or I don't know, you don't know what you're doing. Maybe I don't know. But I've used enough fibular nails that I've never had that happen. So I think it brings up an interesting point. Have you ever been in a case where you get 80% down the road and have to stop and turn around and be like, all right, that something doesn't feel right?
Sure. Yeah. I mean, and it's especially difficult when you've already put in hardware and you know that there's a good chance a decent amount of that hardware you won't be able to reinsert and use in any way. And then you know that it's wasted. We always try to be mindful of how we're spending healthcare dollars, but at the end of the day, you're there to have her have a good outcome. And sometimes you just have to make those decisions, and it's a hard call. I had a midfoot Charcot. I think this was last year now, that my plan had been to put in a midfoot nail down the medial column, and I had everything prepped, and I was trying to throw that wire, and luckily they hadn't opened the nail yet, but we had everything had been on that trajectory to put that in, and then just could not get that guide wire in a position where I was happy with the reduction, but also thought that it would be like inappropriate alignment, because you kind of have to, have things just so that way your cross-locking screws are in the appropriate place. In any case, had to completely abort that mission and switch to plate and screw fixation, which is definitely, just a very different animal than putting in a nail. So it's hard when you have like a certain plan in your mind, but that's why you always go into the OR, right? With like plan B and C and D and E, and you just go from there. So
yeah, it's extremely frustrating because, in your mind, you see it playing out one way, and then you've devoted so much time and energy. You're like, well, maybe if I just do this. And I think some people, maybe, I work with more people trying to find their way back in residency. Now with the student, I'm like, go ahead, you can do whatever you want. I'll fix it later. Like, go for it. That's, our residency director, Dr. Burns, always said, there is nothing that you can do that I can't fix. And that kind of made you think, all right.
Yeah. No, it gave you the confidence to be like, okay, this is all right. I can do this kind of thing. Yeah.
Right. And that's what I tell the students. I'm kind of like, don't worry. I'm not going to let you do something that I can't fix.
And that's what it is, right? Is like, I'm watching you as you should be when you're a trainee. Right.
But anyways, it's hard when you go down that path, and where I was going with that is I tended to see more residents, try to throw a wire, and then, well, that didn't work. Maybe try this and try that. And then you've Swiss cheese the bone, and you're never going to find it, because now there's 80 holes in there. It's going to find one of those 80 wrong holes, not the one right hole that you want. And so point being, it's hard once you've kind of tried to do something. You're like, I could get it. I think I can get it. And maybe you can, but at some point you have to be like, you know what? I got it. We're going in a different direction. And it feels weird. I'm sure the OR is like, yes, we got to pull all this out and start over. It's like, too bad, man. Like, we got to do what's best for this patient. I got to do what's best, what I think is best in this situation. So I don't know. That's a hard decision. I haven't had to do that many times, but I think it's a sign of experience when you have done enough of them, and then you can feel, this isn't right. We got to do something else. You can pull the plug a lot sooner versus if you're inexperienced, then you're just like struggling, and you're going to tend to keep struggling. But
or you haven't seen people far enough out to know what happens if you were to leave it like that.
That's true.
Right?
That's true.
Yeah, like some of it is like having that perspective of being like, I've seen what happens to these a couple years down the road when from either something you've done or you've seen something somebody else had done elsewhere, and seeing the ramifications of what that can turn into. I think that also can help you, know when to change course, or know when you're right. It absolutely sucks when you just have to be like, we got to pull it all out and we got to do it again. So
the most dangerous thought is, this will probably be okay.
Yeah.
right? You think that like this will probably be
Yes.
okay. Like, whoa, if you're thinking that, like, probably not going to be okay, because you need to be like, that's either the best I can do. I've done that before. You get like a
Sure.
fracture, like, this is the best I can do. This
Yes.
is the best I can do for this person on this day at this time with this anatomy with this hardware. It's not getting better than this. And that's a
Yes.
little different than being like, meh, I think it's probably going to be okay. Like,
Yeah.
ooh,
Yeah.
that's a cringe factor.
Yeah. You're right. It's kind of, it goes both ways. The enemy of good is great, right? Like
Mm-hmm.
you have to know sometimes when it's like, no, they're going to be just this will turn out well. We're not going to, leave them in a bad position, but sometimes trying to get it just a little bit more, just a little bit better, just whatever, you can end up in a worse place than where you started. But you're right. Sometimes and that's really where those are the moments that are hard in the OR. Sometimes knowing when, and making those judgment calls, and that's just part of it.
Some of it you don't know at the time too.
Mm-hmm.
You just have to make the best decision, that what you think is the best decision, and then you'll find
Yeah.
out later whether it was the right decision or not. Maybe you'll never know, but maybe you'll be like, nope, should have gone the other way. Or, oh gosh,
absolutely.
I'm glad I did this, because otherwise this would have happened. So
Yeah.
at some point, I mean, I think that's some of those things in the OR that people don't really think about. They just, I'm going to go do this case. Like, well, what if this happens? What if that happens? I think it's good to hear people like you and I who've been in the OR thousands and thousands of times to kind of get a picture of like what we're thinking and what could go wrong in there, and how you adjust on the fly. And, sometimes you have a good rep who can, oh, I've seen a doc do this. You ever have a rep do that? Like, oh yeah, that's a good idea.
Help you troubleshoot, come up with like other ideas of different things you can do.
Yeah.
Which is great. I mean, it's definitely a team effort. And sometimes, your, nursing, your circulator may say, hey, we've got this one little thing. Like, is that something that would be, like, it really is truly a team effort when you're in the OR, just because, you are the one who's physically doing the case. There's so many people that are ultimately involved, especially in those times when things aren't going well, and you need to troubleshoot a bit. Mm-hmm. Yeah.
Yeah. And then you can blame the rep too.
Oh yeah, that's the best.
What
obviously.
Is this hardware you brought me, dude? What is this? This is trash. What is this?
Garbage.
Get this out of my OR. It's funny. I talk to the reps about that stuff. I'm like, how often do you get blamed? They're like, decent amount. Like,
yeah.
God, that's so weird to me. That's like somehow your fault. Like, guy standing over there, like, what did he do?
I know.
Or she, what did they do? They're just here to help out, and all of a sudden it's my fault that you broke the screw. That, like, I didn't fly to Germany and build this screw. I just brought it, man. Like, how is it my fault that the screw broke? Like, I don't know. People sometimes, I bet we've been around enough surgeons through the years that it's so interesting to see their personalities in the OR too, because sometimes it's very different. Sometimes you're around people outside of the OR. And we've worked with surgeons before, and I know you know who I'm talking about. And to just put everyone at ease, they weren't podiatry or even orthopedics, so put everyone's mind at ease. But you'd be walking down the hall and be like, hey, how's it going? Oh, pretty good. Yeah. And then, you'd walk in the doors of the OR, and it'd be like screaming, yelling, throwing, and you're like, what happened?
Jekyll and Hyde.
Because out in the hall, we were friends. And now in here, I'm a buffoon who can't hold the retractor at the right strength or still enough. And
how dare you breathe?
Yeah, that I am the worst person who's ever existed. It's like, wow, that changed quickly. That was, wow. So,
but again, I think some of that comes from, don't you think, like, different people handle pressure or like stress differently, or some of that's personality. Some of it can even be, ego and insecurity. It can be all kinds of things. But you're right. Definitely, there's a lot of different ways that people act once you get back in the ORs.
I think you're right, because I think it's both. I've seen ego and I've seen insecurity, and they both tend to ramp it up into this like anger festival of like,
Yeah.
does that make you feel good to throw that and call the circulator a name? Like, I don't know. That's not how I would handle that situation. But yeah, I think you're right. I think it's just how people handle stress and how they coping mechanisms. I mean, maybe we need to get them into some therapy and talk it out a little bit. Do you need someone to talk to?
It's hard. I mean, again, there's a lot of people under a lot of stress and strain in medicine. Not just the providers, the physicians, but and not everybody handles it well.
I would agree with that.
That's for sure.
Yeah, maybe they're dealing with stuff in their home life. Maybe they have a stressful life overall.
Absolutely. Yeah. You kind of forget that, right? It's not an excuse for poor behavior, but at least, you kind of forget sometimes too that, it's just a bunch of people that are dealing with all kinds of different things in their life. Sometimes I think that's actually helpful, right? When you're a medical student and you know that you are at the very bottom of a very long chain of people in the hierarchy of medicine, and you're, probably going to bear the brunt of most of those types of things. It's good to just kind of take a step back and like remember, like, they're just like people who go home and maybe they've been in a fight with their spouse, or like they're dealing with a sick relative. Like, I don't know. There's so many different things that can bleed into work.
But I agree with you. There is not really an excuse.
It's not an excuse. It's maybe offers some kind of explanation, but it's not a good excuse for poor behavior.
It's like when our kids are bad and it's like, well, they're pretty tired. I'm like, no, I don't care. I don't care how tired you are. Like, it's a terrible excuse.
Yeah.
The only real excuse that's legitimate is when I'm hungry.
Oh, you are the worst hangry person I've ever been around in my whole life.
The worst? Come on. The worst?
Maybe I just bear the brunt of it more. But man.
Yeah.
Yeah.
I was telling my office staff the other day that you can pick up on it, that you're kind of like, man, you're being kind of, you're hungry, aren't you? And I'm like, no. Yes. Yes. Now that you say it, I'm quite hungry. What do we have? Yeah.
It's so true.
That's
I know.
The only excuse. That's the only legitimate.
You're the only person I know who, as a med student and even as a resident, like, you weren't like I keep a granola bar in my pocket, and if I go all day and I don't eat, like, you were like, no, I will get lunch. Like, and not that you did it in a disrespectful way, but you were like going to find a way to eat a meal during the day.
I could be in the middle of surgery. I'd be like, all right, we got to call time out here, guys.
Not as a student, by the way. Students do not do that.
Yeah. There's a snickerdoodle downstairs with my name on it. I'll be right back.
Oh, shoot.
Yeah, I don't miss lunch. Nobody wants me to miss lunch, though. I'm just being nice to everyone else.
Yeah. No, it's for everyone's
they don't want to deal with
well-being.
Me.
No.
Yeah. All right. Did we teach the people something today?
I hope so.
Yeah. Don't be cranky in the OR.
Yeah. Yeah. Make sure you eat a good breakfast. Don't be cranky in the OR. Yeah.
I wish there was a way to like feed you in the OR. Like, they should put like a little something on the side of my mask so I could, race car drivers, they have the little tube with the water so they can drink while they're going.
There you go.
I need a little milkshake coming into me during.
You could design some kind of like straw that's like specially like comes up and then it makes like a turn to go back, and it's designed to go underneath a mask. Yeah.
I need some milkshake stat. Otherwise,
You're
I'm about to get cranky. Y'all aren't going to like it. All right, so we talked about some fifth metatarsal fractures that were kind of strange, and then this unusual distal fibula fracture. So we kind of tried to talk to you guys about some weird cases and how you adapt on the fly, and some people handle stress better than others. And I'm good at handling stress unless I'm hungry. And you're pretty even keel most of the time. How do you stay calm in the OR?
I don't know. I mean, I guess, some of it might just be I'm not one to get too ragey, angry about things. So one of these days I'm going to try it, though.
Like our son playing a video game right now and yelling?
Yeah, man, he's just an animal.
Maybe he's
I think
hungry.
I'm going to try it, though. I'm going to lose it one day. I'm going to get really, just see how it feels.
I think you should lose it once. Maybe like kind of early on. You want to establish like
you only have to do it once.
I'm nice, but then just one day just go like boom crazy. Mm-hmm. And then you do that to your kids too. Like, whoa, there's another level here that I don't ever want to see again. And I'm going to do what I can to stay away from that.
To avoid that,
Yeah, you just have to hit that level once in the OR and word will get around. Like, she's cool, but don't forget to whatever.
Yeah.
She will lose her mind.
One of these days.
I'll be.
Give it a try.
Can I be there for that? I want to see that. I want to see you throw something in the OR. Like, just
I know. I bet it feels good. I mean, I bet it's cathartic, but I know. We'll see.
All right. Well, thanks for joining us on another episode of Pod Patrol with your host, Dr. Jeff Dikis.
And Dr. Ashley Dikis.
We'll see you guys next time.